1, 2. Hey, 1, 2, 3, 4, 5.
Absolutely. Hi, Manhaj. I didn't know whether we'll. This is all. I've just come for all of it. It's a first one. I've been You know what I've gone for like weeks, but now it's quite feels quite warm in here now. Oh, so stressful. So stressful. The whole thing feels stressful. Hello. This is the third time I've been out.
So I think members were. Okay, welcome members to the meeting of the Leeds Committee of the West Yorkshire Integrated Care Board. It's wonderful to see everyone in person. I'm chairing the meeting and I've been appointed the independent chair of this place committee, which forms part of the wider West Yorkshire Integrated Care Board arrangements. It's really wonderful to see you all together. We did have one meeting last together online. So this is our second meeting, formal committee meeting, but the first in person. So it is wonderful to see you all here. So our meeting's being live streamed to the Leeds Health and Care Partnership YouTube channel, which is wonderful. Thanks very much for organising that. And if anybody's watching, that's lovely to see you. I hope you enjoy the meeting. So just to make a comment about the microphones, we have got microphones so that we can be heard on the live stream, but also so we can hear each other. Only one person can use it at a time, and you have to press a button on to speak and off in order that someone can use their microphone. So please, can we all remember to turn our microphones off when we finish our point? I'd like to now just thank the venue for having us. It's really wonderful to be here at the New Wortley Community Centre. We do try to meet in public and community venues to reflect the work of the city, really, in our communities. So much good work has gone on here for many years to support the health and wellbeing of the population locally. We've met here before and as a health and wellbeing board many years ago when I was in a different role. So it's lovely to be back, and thank you to the venue for having us today. They do skill building classes, youth groups, ex-offender support and food and hygiene banks and counselling services here as well for the community. So they are really doing so much for our local people. So we're going to now just go around and do introductions. So I'm Rebecca Charlwood and I'm the chair. So if I would start with Victoria, please.
Hello everybody, Victoria Eaton, Director of Public Health at Leeds City Council.
Thea Stein, Chief Exec, Leeds Community Healthcare.
Hi, Jason Brock, GP, Chief Clinical Information Innovation Officer.
Chris Mills, Chair of the Leeds General Practice Confederation.
Cheryl Hobson, Independent Member of the Leeds Committee of the ICB.
John Beale, Chair of Healthwatch Leeds.
Corporate Governance Manager.
I'm Tim Riley, Accountable Officer, brackets Leeds for the West Yorkshire ICB.
Hi, I'm Visa Peshon-Sykes. I'm the Finance Director for the Leeds Place of the
Hi, Sam Ramsey, Head of Corporate Governance and Risk for the ICB in Leeds.
Good afternoon, Sarah Munro, Chief Exec, Leeds and York Partnership Trust, and apologies, Chair, I will need to leave at 10 to 3.
Hi everybody, I'm Jo Harding. I'm Director of Nursing for the ICB in Leeds.
Hi everyone, I'm Yasmin Khan. I'm the independent member of the Leeds Committee and Chair of the Delivery Health Inequalities Committee.
Hi everybody, I'm Shona McFarlane, Deputy Director, Adults and Health. I'm standing in for Kath Roth today. Thank you.
Hi, I'm Stuart Morrison, Team Leader with Healthwatch Leeds.
Thank you everyone for attending. We've also just got Julian Hartley who's arriving, who can introduce himself once he's sat down. That's all right.
Hello everyone, Julian Hartley, Chief Executive, Leeds Teaching Hospitals.
Thanks very much and welcome. Thank you very much. So we're going on to apologies and declarations of interest. So just noting apologies, Kath Roth has sent her apologies and Shona McFarlane is deputising and Shanaz Gull is also sent her apologies and Francesca Wood is deputising for the third sector, but she'll be arriving from 2 p.m. onwards. So could I ask members to declare any interests presenting an actual or potential conflict of interest arising from the minutes at the agenda today? I can't see anyone with any hands up, so I'll take that as no interest to declare. So we'll go to the minutes from the previous meeting. Can I ask members if there are any issues with the minutes? We just need to note that Joe Harding was in attendance at the last meeting, so this will be reflected in the final version of the minutes that is published. Are the minutes otherwise agreed? And are there any matters arising? I'll take that as no matters arising and agreed minutes. Okay, so going on to the action tracker. Can we note that the actions from the previous meeting included on the tracker have been completed? Any comments about that? Thank you. Okay. Right, so we'll go on to our next item, which is how we like to start our meetings, which is to share a lived experience of health and care services. And that's in order for us all to always have at the centre and forefront of our minds when making decisions and having discussions about services in Leeds, to have people and how our decisions affect them right at the forefront of what we are thinking about. So Health Watch report to the System Oversight and Assurance Group, Citizens' Voice, in May 2022. It provides an overview of key issues that Health Watch have been hearing about over the past couple of years, with GP access, and as we know, that's a major issue for lots of people recently, being key. And it links to item 30, the Primary Care Network Enhanced Access Service, on our agenda today. So it's timely to hear Stuart Morrison from Health Watch, who will present to us. So Stuart, can I hand over to you?
Yeah, thank you. I think it's maybe a little bit different than what's on the agenda because we've recently published a Health Watch Insight report. This was produced by my colleague who is now an Associate Director for Health Watch covering West Yorkshire. West Yorkshire ICS asked for an insight report to cover maybe the last 18 months about what people have been telling us in Leeds and other areas. So this is we've not gone out to speak to people for a particular reason. This is insight reports maybe from SOAG, from the work we've done, from the inquiries we've received. And if I'm honest, the vast majority of it has come from Leeds, and everyone else has said, yeah, we're hearing that as well. So this is quite timely that it's come here. So if it's okay, I just want to go through and give you some of the, a summary of what people told us, okay? And as you'll be aware, I think you would have heard quite a lot of this and know quite a lot of this as well, because this is stuff that's been fed back to you guys on a regular basis. And as you know, many of the issues that were already there have been exacerbated by the impact of COVID and now the cost of living crisis as well. And then just to kind of put in the forefront that along with challenges faced by many members of the public, additional challenges are going to be faced by those with the greatest health inequalities, additional communication needs, and people living in poverty. I think it's important to recognise this, just because they have those extra needs, for example, language barriers. So I'll give you a summary of the report, and I've put one on everyone's desk, and I think I've sent a link to Harriet as well, so that can be sent round. And it's well worth a read, I think. There are a lot of quotes and comments from people in there that gives you an insight into how some of these things we talk about has an impact on people as well. So the first thing in there is around GP access. And I want to say that at Health Watch across the region, we know how important GPs are to members of the public and what a pivotal role they play. And we very, very rarely get any kind of feedback around, and this applies, I suppose, mainly across the board. We don't get much feedback, negative feedback around kind of clinical care and treatment. This is more around the kind of processes and how people access their treatment as well. So that one of the main things is around GP access. And within that, people are telling us there's a need for more face-to-face appointments, the real challenges of booking appointments, and we're getting that every day. I think, John, you had one yesterday, didn't you, with your local practice? the variation between different surgeries. We've got some feedback around some really brilliant ones that are doing everything right, and then others just cannot be seen. Triage, it's a word that people don't understand anyway, but people don't know why they have to tell the receptionist everything. They have a real struggle with that, and I think communicating that to people as to why they might need to tell the receptionist things would alleviate a lot of issues. And then staff attitudes, a lot of that is to do with receptionists, and again links to the whole triage process and people not understanding why they have to tell you everything, whereas previously if you said it was personal, they would go, okay, I'll put you through to a GP or make an appointment. So there's I think a real issue there, and I think just communication can sort that out. Routine checks being missed. We've got some examples, like an annual diabetes check, people not being seen for 3 years. So kind of feeling a bit in limbo around that. And I think some people think that other services are open, why GP practices kind of falling behind. That's an opinion of people anyway. And then the accessible information standard, and I think this can apply across the board, but within practices we've been hearing that it's not been applied across all surgeries. So people with maybe sensory impairments and other disabilities such as autism, it's having an impact on them as well. The next big thing we're hearing around is dentistry. We get regular calls about this. I'll give you an example. So the main thing is waiting lists or not being able to be seen by an NHS dentist in Leeds. There are no NHS dentists taking on patients at the moment. We've got waiting lists of up to 5 years. Just an example of how many we're getting. Before the pandemic, we were getting 41 inquiries a year. Last year, we got 365 inquiries. So it's a big jump. And we're not an NHS organisation. A lot of people come to us when they don't know where else to go as well. So the number is going to be far bigger than that. So as well as not being able to get seen, that leads to the need for emergency dental care. 111, slow response can take up to 3 days to get back to someone. And then dental practices are meant to offer emergency treatment to anyone who calls. That's not happening. It's not happening in Leeds anyway. And then the other thing we've been hearing around lately is children's orthodontics. There's been a lot of challenges. There was a recommissioning of the service across West Yorkshire at the end of March with a new contract starting on 1st of June. And there are people that have still not had any and don't know how to get treatment. Been stories of parents having to cut their children's braces with pliers because they're in so much pain. A lot of these with the GP access in dentistry, we've got a lot of kind of horror stories. I spoke to a person yesterday crying on the phone. They can't eat because their dentures had broken and they just can't be seen by anyone. So I'm just kind of skimming through this. There's a lot more in the report. The impact of the cost of living. Now, this is something that we're starting to hear more and more, especially from our third sector partners. Some of the issues that kind of relate to health and care, not having enough money to travel to appointments, not being able to afford to get taxis or even the bus in some cases, then fears that they might not be able to afford medication. And then as there's a move to kind of more digital, and there's going to be people excluded that can't afford to put data on their phones to have these appointments. There's the worry about further challenges with winter approaching and having to make those tough choices that I think we all know about. Then another thing around access to exercise and leisure. For some, it's maybe seen as a luxury, but others it's essential. And not being able to afford that may have a detrimental effect on their health. We've got some examples in relation to travel costs, not being able to afford to maybe. We continue to hear the feedback about the challenges people facing and their impact. long waits of maybe 6 to 8 weeks to be seen when you're in crisis. We're hearing more about delays in treatment, how that's impacted on people's health and well-being, and that can include a deterioration in their physical and mental health while they're waiting for treatment. There might not be enough communication around how they manage their condition while they're waiting for treatment, and then a lack of communication in general around delays in treatment. So what's happening? How long are you going to have to wait? If people are told, we found that, you'll be waiting 18 weeks and then we'll be in touch with you, then they'll be happy about that. But if no one gets in touch with them after 18 weeks, they're going to start worrying. But the simple things of keeping people informed along their journey. Then we've got digital inclusion, which we've been doing quite a lot of work around. And I think, as we know, that the move to digital excludes certain groups and communities. Talking about maybe people with learning disabilities, older groups, people whose first language is English. So it should really be an option, but it's not suitable for everyone and not suitable for every type of appointment. And that comes back to where we talk about the GPs, where people are wanting more face-to-face for certain things, where digital is offered for a lot in some practices. And then people should have a choice, as it works well for some, as we know. Some things we've picked up recently around quality of care, and this has been mainly in hospital. It could potentially impacted by staff shortages or staff being busy. I had a couple of recent experiences of people, one with a disability and another quite a young person in there, and they were left in their beds in their own excrement and sick for a period of time, and they obviously got upset. This has been shared with the complaints team in Christina, but they thought that everyone was too busy to see to them. And we've done another report, which I'll share after this, around leaving hospital and discharge, and that comes out a lot in that as well, where there's a perception that people were too busy to look after them and see them when they were in hospital as well. Another one is around health inequalities. So I think that, as I mentioned at the beginning, everything that we talk about in this report, people with increased health inequalities are going to feel this more. So there are increased barriers to access, digital exclusion and poverty, potential gaps in service provision for certain groups. So, for example, people with maybe learning disabilities not knowing that they can get an extended appointment, people not feeling involved in their care. And then there's a need for better working with local organisations that support these communities as well. So, as I said, everything in this report has a more significant impact on those who already face the greatest health inequalities. And I think that gap seems to be getting wider as well, where we've got to move across the city to try and get that shortened. And then the last one on there, I've talked about the hospital discharge report. So some of the things that have come out of that around poor communication, but there are some really good examples of positive communication, and when that works, the discharge process and support in place. And again, in this report, there are really good examples to back some of these up of how it impacts on people. That's a summary of the report, and we've got a few kind of key messages here. And I did mention around at the beginning, we don't really hear anything negative about the quality of treatment. People are generally very positive about that, but it's just everything that goes around it seems to have an impact. So for us, I think the key messages and recommendations are around access. There should be clear and simple systems and effective communications that allow people to access primary care services or appointments when these are needed and in a way that works for them. Ensure the needs of these communities are central to the design of health and care services, development and delivery. Variation, consider how to tackle variation across the system. And then, I'm sure you've heard, Anna, the 3 Cs. Communication, for me, I think this is key. And I've been involved in Leeds, we had a complaints group. And in the top 3 of complaints, for all the years I've been here, communication has been in there. I'm just thinking, for me personally, it seems one of the things that can possibly be tackled quickly, but yeah. So good, clear communication is key to delivering a person-centered approach to care. Compassion, another central part of person-centered care. So this plays a vital role in shaping people's experiences of care. And then coordination. So good coordination helps people have a positive experience and improves outcomes, especially for those that have multiple and interacting health conditions. I think the 3 Cs, if you can manage to crack these things, probably a lot simpler than I'm thinking, and you're halfway there. So that's it from me. Just a brief summary of the report, which I hope you do get a chance to read. I think it's 40 pages, but it's full of quotes, and it's not like a heavy document to read, but there's some really interesting and powerful stuff in there anyway. So.
Thank you very much indeed, Stuart, for representing such a breadth of feedback that you've gathered, and thanks to Health Watch for the work that you're doing.
Yeah, thanks, Stuart. Just first of all to say thank you for this report. I think it's really important, and I think it's an important sort of moment for all of us actually, in terms of engaging with the concerns and the comments that come out of this. I just wanted to sort of say something about the obviously, my responsibility around people's experience in hospitals. Certainly, just to kind of amplify some of the issues, I have spent the last 48 hours sort of embedded in our emergency departments to see for myself the experience of patients and to spend time with our teams and staff, and certainly a need to eliminate that. But I have to be clear that the pressure on staff is in this system and this city in relation to reducing that number of patients, which can be anything from 280 to about urgent care. This is a situation that's repeated in hospitals
that we heard about anyway. So that's why it's not in there. We report on what we hear from members of the public. So, yeah.
And thank you for raising that point as well, the comparison between the cities. Even though everyone is struggling and finding it difficult, we have to celebrate some performance where we are better than perhaps we could be. Thank you for that, Julian, as well, that response. Dr. Beale, would you like to come in?
Just very briefly, Stuart did mention the situation I had yesterday in terms of access to a GP. And I have to say, it's very variable, even within one practice. I made a phone call to my practice. I wanted to have an appointment, not urgent. So I phoned on what I should do. I phoned later in the afternoon. I got an appointment, and I said I was very happy to have a telephone appointment. I got an appointment for this morning. The doctor thought I ought to see a physiotherapist. Said, could you come in this afternoon? Well, I couldn't because I'm here. But, early on in the afternoon, what I thought was a bad experience, not for me personally, but making the call, followed up by very good experience, both for an appointment with the doctor and physiotherapist.
That's really interesting. Thank you very much for that personal account. And I think we've all probably got examples of our interactions with the health service ourselves. Certainly I'm a citizen of Leeds. So I'm just going to bring Tim in, and then we'll go to Gaynor. And then if we can probably finish this item, that would be really Tim.
Yeah, thank you for the report. And I know we've seen it in sort of probably a number of places, but still remains powerful in what it conveys. I always wonder when I see a report like this how on earth we address it, because there's so much, and as you said, communicate. Well, I suspect communication will always feature in a report like this forever, because it's the sort of number one difficult challenge we seem to face as human beings. I guess though, what I suppose I wanted to say is there are a number of pieces of work which I think will address a lot of these issues. Julian has mentioned the most serious one facing us. And that does absolutely remain top of our agenda around the flow of patients through the hospital and out into the community. And that if we, not if, when we, because we need to make a real difference in that, that will have a significant impact on a lot of those underlying issues that you described. And it's quite interesting, I think, that we don't talk as much about elective. We don't see this issue around elective care featuring in what people say. But actually, the knock-on experience from a number of the other issues in the report is on actually the ability to treat people. And it is good as the work Sarah and other colleagues around the table are doing around in the community mental health and the reform, our really different mental health model around access to psychological therapies that's much more comprehensive than other places. I think as we deliver those things, it will have an impact on a lot of the issues that are seen in here. So we mustn't sort of get diverted off into trying to address things at a sort of single issue basis. We need to implement those real changes with this in mind. And then the third area is around primary care, and we do have to acknowledge that, the access challenge. There's always a thing between hard numbers and people's experience, but in the end of the day, we're a people's service, and there's been a significant shift in people's perception and experience, let's be honest, of accessing GPs, not in the quality of care they receive. I think John's story illustrated it really well. And again, I do think we give a huge amount of attention to, for example, discharge and flow, and it may be something as a committee we want to consider how one of our subcommittees, perhaps the delivery or quality, really does some deep dive work about understanding the variation across primary care in the city, because we do need to address it. The consequences of not addressing it are two ways. One is people turn up somewhere else in the system, often at the hospital front door, or sometimes certainly at the front door, or they don't turn up at all. And they sit and go away with their problem. Now, sometimes, in my case, you know, sore shoulder, not getting a GP appointment or not bothering to find out because it would probably take too long, and it went away. That's great. But actually, we know that there's a lot of late diagnosis in the system. So we're seeing that our comparators are not like that. And therefore, one of the things we may want to consider as a committee is how we manage in our relationship with the West Yorkshire Partnership, what the appearance of performance, because our performance compared to core cities is generally pretty good, and that should be our comparator, big metropolitan boroughs. Compared to some other places, it doesn't always look quite so good, and so we may want to consider that. That's just a sort of spin-off. It's not directly related to this report. I'll stop there.
Thank you, Tim. That was really helpful. It made me think a moment there. I think I've popped in the list the other minute. About recovering from the COVID pandemic. We haven't mentioned it yet, but with issues that they may not have been dealt with during the COVID pandemic. So that's just, I'll put that out there if anybody wants to pick that up. I've got Gaynor, and then I've got Dr. Mills, and I've got Yasmin. Thank you.
Thank you, Chair. Thank you for the opportunity to speak. My name, for people that don't know me, I'm Gaynor Connor, Director of Primary Care and Same Day Response for the ICB in Leeds. First of all, I want to echo really welcome the report. Again, to give assurance to colleagues as members of the committee. So the Primary Care Board and the working groups that are particularly focused on GP access and GP experience have Health Watch as full members of those both boards and working groups. We take very seriously the insight that Health Watch are able to provide to us through this report and through others. We've been able to use some flexibility in the National Quality and Outcome Framework that sits in the GP contract to have a particular focus of a quality improvement module specifically focused on access and experience. So each of our 92 practices are engaged in that quality improvement module, which will give us some richer information in terms of some of that level of variation that Tim mentioned. And whilst I wouldn't want this in any way to be defensive, I think it's useful for members of the committee to have some context. I think in terms of some of the demand that general practice is facing currently, because I think we hear that in other parts of the system. So I think, you know, the scale of what's going on within general practice, we've got 404,000 appointments within general practice each month, which equates to about 18,000 appointments a day being offered. 51% of those are with a GP, and 72% of all appointments are face-to-face. We know that around 43% of appointments are booked on the same day, and about 72 appointments being booked within 7 days. So I say none of those figures are there in any way to be defensive. It's really just to give some sense of the scale of what is going on in the sort of general practice sector. But as I would want to leave committee members assured that access and experience is the number one priority in terms of a number of work streams that we've got in the city.
Okay, thank you for that. Thank you for that, Gaynor. That's very helpful as well. Dr. Mills?
I don't need to add a lot more than what Gaynor said, really. Welcome the report. There's work underway over the course of this year. I'm sure the practices will embrace that, and we've got support from the ICB to do that as well through various flexibilities. It's interesting, we changed model literally overnight to an online first, phone first system without any thought or experience. It was a response to the COVID pandemic, and obviously that was less than ideal doing it that way, and we've got to learn the lessons of what works and what worked before and what didn't, and make a hybrid system and do that through a quality improvement exercise. Now, whether we'll then suddenly be able to return to the satisfaction levels we had before the pandemic, I don't know, because we're still seeing a lot of increased demand, but hopefully we can make a good show of it. Thanks.
Thank you. And I think that sort of picked up the COVID question that I'd sort of had after hearing the contributions. And Yasmin, and then we'll move on, if that's okay. Thank you.
Again, thank you for the report. I think it really alerts us to some of the challenges that the committee is already aware of. And I think it's about really re-looking and refocusing for us. And just listening in, I think the workforce challenge is a major challenge for us. And we need to really have a really strategic view in terms of how we address that, because it's an ongoing concern. Because that really links it with the 3 C's around how we communicate, you know, around how we provide compassionate and coordinated care. If we haven't got people around to do that, that's going to continue to be a challenge. And I think the other one, and a really important one, is around efficiency. Because if we've got people that shouldn't be either in hospitals, taking up bed space, that could be in the community, we need to refocus some of our energy into talking about the left shift again, around bringing some of that early intervention work back into, you know, repicking that up. I think we're doing a lot of that work, but some of our resources, maybe we need to reconfigure some of that.
Okay, thank you very much. Just about, I'd thought about that when in a previous role, I used to be informed and to make decisions around the Better Care Fund, which is around keeping people out of hospital and help people get out of hospital and stop people going in if they don't need to. And very detailed piece of work. It's been really interesting discussion. I think been really useful for all of us to put that right at the front of our minds, like I said earlier, as we go through the agenda. And you're very welcome to stay, but I appreciate you may need to leave as well.
I will need to get. I live in Oxford, so I will need to get back at some point to pick up the sprogs.
Thank you very much, and good luck with all your
Thank
work.
you very much, everyone.
Thank you. Okay, so we'll go on to questions from members of the public item. No questions have been received in advance of the meeting. We do welcome questions from members of the public about items on our agenda, and we have a standing item at the beginning of each meeting, such as this. However, this meeting cycle, we were unable to widely publicise the opportunity to submit questions due to the sad passing of Her Majesty Queen Elizabeth II and the period of national mourning, which restricted our communications. But I ask members of the public in attendance if there's anything they would like to raise at this point. Thank you. Okay, so we'll go on to the place lead update. Tim will introduce the report, which we have in the pack, provide an overview of highlights, particularly around winter planning and system resilience more generally, and then we can have a short discussion if that's helpful. Thank you. Tim?
Thank you, Chair. I'm not going to say too much. I'm conscious we're slightly behind time, and we've probably picked up quite a lot of this already in the preceding conversation. So 5 points just to note. The first one is, of course, the sort of constitutional changes in terms of the late Queen and the King. We've also seen quite a significant change in government, and therefore we would be expecting and are experiencing a change in focus in terms of our new health secretary. So I think it's worth bearing that in mind because of some of the expectations and the focus that we will expect to see, particularly over the next couple of years in the lead up to an election. So I just wanted people to be aware of that. I don't think any of those things are a bad idea, and they're all things that we talk about quite a lot. I guess the issue is where our energy goes in terms of beyond that. So that would probably be one of the challenges. I'm not going to go into the detail. It's in the report. And we're still waiting for a bit more clarity. Those are sort of where the hints are that are coming through. The second thing to mention, obviously, is the one Julian touched on earlier, and the pressures in the system. And they are going to be compounded by the cost of living crisis, the COVID, flu, the whole winter season this year is going to be incredibly difficult. I think it's worth committee members knowing that there are, in effect, 3 elements of a total plan, or 3 plans that are focused on this. One of those plans is the ongoing programme of work to improve the flow out of the acute hospital, which is a whole system plan, a detailed programme. We have, there is now considerable intensity focus on that. The second plan is what we normally look at as in terms of our winter plan. I think really importantly this year, it's how we relate that to work. For example, colleagues council around the financial situation, warmth, and then of course things like the flu and COVID vaccination programs, which are preventative from an NHS point of view. They are there to, if they're successful, they reduce the demand on us, but also how we will manage the demand that will come anyway. And then finally, given the seriousness of some of the challenges that we currently face and what we are concerned is coming this winter, we've felt it right to look at what we'd call an extremist plan. What are those steps that we will might have to take, really wouldn't want to take, in terms of service levels, collapsing workforce, etc., if we have to. So that planning is underway as well. That's not something we would normally do at that level of detail, but I think it's right the committee and others are aware of that. So pressures in the system and planning are really key. I'm not going to say too much around the development of the Leeds partnership. I think it's important we note that in the report. People may want to ask some questions on it. There's some really interesting stuff, as well as getting the basic governance in place and so on, which we've done with the formation of the ICB. I think the more interesting pieces are more about how we want to work as an integrated system, and the work that colleagues Julian and Sarah and Thea in particular have been doing with the Department of Health in terms of the Leeds hub and the opportunities that presents to us. So some important and more interesting pieces, as well as the basics that we need to put in place and have put in place. Giving one example of a piece of work that's going on, it's going to scrutiny. It's been an ongoing challenge across the system around neuro and stroke. So I thought it was just worth making sure that colleagues were aware of that. And then finally, I'm really interested in what people would want in this report. I've written a report, start for 10. If in future people want something different, I'm proposing not to make it longer. Been in meetings where these reports are so long that I don't read them. So I want it to be fairly concise and give people the opportunity to ask.
And for that, Thea, thank you.
It's a hard question, Tim, and I think it's something that when this board we finish the meeting, I'm not suggesting we need to continue to reflect on, are these all the right papers, and they would put pressure onto our board. The community neurological and community stroke, actually, and it went to scrutiny this week. We would mention, and it's important, but I'm trying to think about the balance of a major partner in Leeds. The thing that's missing for me is understanding, what are you obsessed with? We're obsessed with CAMS. And for me, we're also obsessed, of course, with the cyber issue that we've got going.
In all the work that we do, in the neurological rehab paper, it talks about involving the public and the third sector. On Tim's document, it talks about on 4.5. So my comment is, why haven't they been involved already? And did we ought to make sure, or I would say we ought to make sure right from the start for these sort of working groups. And the second thing was, in the stroke paper, it mentions rather briefly, I thought, prevention. In terms of the left shift, they talk about prevention in terms of medication mainly. And of course, that's important. Medication for thrombosis, medication for other relevant conditions, hypertension. And it talks about some of the factors which predispose to strokes, but it doesn't really go into the prevention. So it talks about cholesterol, but it doesn't mention diet. It talks about smoking. It talks about high alcohol consumption. Really, we need to draw out in more detail in these reports exactly what we're going to do in terms of the left shift. So I think, I'm not criticizing these papers specifically, but we need to learn the principles that ought to be addressed in all levels.
Okay, Tim, would you like to? Okay, Tim, would you like to?
Yes. Sorry. Timing. They may want to, I think this one would be good in terms of the implementation of the arrangements rather than in the development of them, because it's not being one and not the other. In terms of, but it's right, it is a principle, and it's a principle we would want to check. So I think it's the right question to ask. I think in terms of the second one, yes, we do need to, and not a report of all the work being done on stroke, and we would want to, through the report of our healthy population board, be looking at the prevention, and that are the things that I think we will do in terms of deep dives and focuses in other areas, and that can then come through then, because you'll know as I do that a lot of the things that prevent strokes also prevent lots of other things. That feels more sensible that we do focus on that prevention side when we're talking more generally about what we can prevent. But yeah, I agree. It should be absolutely on this agenda at times. So yeah.
Okay, thank you. I've got Joe, and then I've got Julian. Thank you.
It was just to quickly endorse Thea's point, really. We had a similar conversation at the first Quality and Patient Experience Committee in relation to a highlight report of quality, and to a highlight report also reflected appropriately at West Yorkshire to shake down.
One of the bullets about a small group of chief officers have been working together to produce a shared mandate and common narrative. And I'm just that those chief executive, you've got the diversity of the sector of the NHS, to make sure that they're equal partners around the table.
So I think it's probably important to set the content in, make the case to the department. So once we done some initial work. We then went out and spoke to wider colleagues, GP Confederation, Third Sector, and so on, and then have taken back that feedback into our deliberations and continually involve them in that process. So it's not that this is done somewhere mysteriously, completely away from others. It was more about to the department around how they might want to work with the NHS differently. That was the initial. I think it's taken on a bit more of a life than that now, but that's where it started. But yes, we have involved the third sector and continue to involve the third sector.
Okay, so noted the contents of the report and we have advised on the content of future place lead updates. I think we're comfortable that we've done that as a committee. So we'll move on to the next item, which is the subcommittee updates. There are 3 subcommittees and we have just completed our first cycle of subcommittees and then a full committee, which is today. So I'm the chair of the Quality and People's Experiences subcommittee, and we have the other independent members who chair their subcommittees as well. So this item is intended to bring a short summary of the paper and the meetings that we had to the committee for further discussion, clarification, points that you'd like to raise to the main committee for the minutes. And if anyone had any discussion items to raise, that's fine. We've got 15 minutes. We don't need to use the full 15 minutes if there isn't anything to particularly discuss. So I will just give a very short, brief update about my subcommittee, and then I'll hand over to Yasmin and then to Cheryl, who will do theirs. So we'll take comments after each one. So we met on the 7th of September for the Quality and People's Experiences subcommittee. It was in person. Very well attended in Headingley Heart venue, and as was an expression of an overarching concern regarding system pressures and workforce challenges. And it was noted that a place-based programme of work was in progress. Now the report's there, and we've got the risk register later on, which was also brought to the Quality Committee. But if anybody would like to raise anything else that we discussed, or ask any questions, or make any comments on the quality.
You talked about going to the West Yorkshire Committee and raising the issues about system pressure and workforce pressures. So that happened before this meeting.
Would like to respond or? Who wants to take that? Sam?
No, it's fine. No, absolutely not. So I think in terms of that governance route, what Rebecca meant there was that it was coming to the Leeds Committee of the West Yorkshire Integrated Care Board. So that is the route from the subcommittee to here. It's not Yorkshire. And then the governance from here to the West Yorkshire Integrated Care Board there will be a similar report going from here, which will feed into the committee. On this occasion, it hasn't worked because obviously the West Yorkshire Integrated Care Board was on Tuesday, whereas ours is today. But we've tried to align it so that it works more fluently in the future. That makes sense. Great. Thank you.
Thank you. Yep, we're all getting used to the new governance arrangements. Don't worry. And Joe, did you want to come in? Any? Did you?
It's still working through. So we're working through because there are different reports that need to be submitted. So we're making sure that, as Sam said, we're aligning our meetings so that they follow suit.
Okay, thank you. If we're comfortable with that, can we move on to the next subcommittee, which is Yasmin.
Rebecca. So we met, the Leeds Delivery Subcommittee met on the 5th of September. Our meeting was virtual. We had reasonable attendance. We had people, just because timing clashed who couldn't attend, but we had their deputies stepped in, which was great. Again, really fruitful conversation meeting, and really again, just Thea, what you were asking around the purpose of those committees is ensuring that we're able to alert, advise, and assure. So really, those three strands, and escalate anything to this committee. So I just wanted to pick up around the alert, which I think have already been picked up by the insight reports from Health Watch. Some of those are on there. The subcommittee received the delivery performance report from Tim, which is appended to the report, and the following were flagged up. Although cancer performance is improving overall, there are specific areas where cancer improvement is not to the level we would want it to be. The demand touched on earlier on colleagues in mental health services were acknowledged, and indicators displaying the right direction. So we're kind of working toward the right direction. And then in terms of appointments for GP access, we know this has been an ongoing concern for a number of years now, and it was demonstrated that they were growing. However, it was important to note that people's experiences had fallen. So that again correlates with the earlier report, and it's great that we're saying the same report, and it's great that we're saying the same things. The biggest challenge and the major area of concern was in relation to acute and emergency pressures. Again, we've touched on these and the consequences in discharge. A programme director and programme office has been put in place to oversee a complex set of changes and improvement. And then very quickly, just in terms of advising, there's a number of things we've advised, but the subcommittee agreed to receive future updates, recognising the need to be realistic in terms of what can be contributed to making the difference and considering investment and the investments. There was a suggestion to focus on top priorities, maybe 3, so we focus on and measure some of our impact. And then again, we've looked at around the core plus 20 approach, but we've noted that we will be focusing on the 10 most deprived areas. And then just lastly, from me on assurance, the subcommittee were asked to agree a level of assurance. It was agreed that given the information presented, a level of limited assurance would be more appropriate. And that was around performance, quality, in some areas is not in line with the agreed targets that we had agreed. And I think that's it from me, unless there's any questions.
Thank you. That's very helpful. Thank you. Any questions, comments on the delivery and health inequality subcommittee? I should give it its full title, which is okay. Thank you. And so I'll hand over to Cheryl Hobson, who you can explain your own subcommittee. I'll leave you to it.
Thank you, Rebecca. Yes, I chaired the Finance and Best Value Committee, which took place last week on the 22nd of September virtually. Really good attendance and lots of discussion, which was great. Points to raise with this committee in terms of alert relate to a business case that we were presented with around community diagnostic centres at 3 sites across Leeds. So the detail is in the update report, but just to draw to your attention that back in July, so prior to the formation officially of the ICB, a business case was submitted for, I think it's just under £4.5 million capital and £652,000 revenue. As a committee, that the model for community diagnostic centres was positive in the sense that it would improve access to people in Leeds. There are 2 further tranches that are expected to be bid for towards the end of the financial year, and we agree that that should happen around December time in order to get feedback from the first tranche that's been bid for. So there's